Thank you. Well, I'm really impressed by all the lectures I'm seeing today. Well, I hope all of you have enjoyed what you see and you have learned just as I learned myself as well. Very nice lectures for like all the different approaches. This is gonna be kind of an exercise for you to apply what you have heard already in this case. And just to make it short, I'm gonna start, before starting, I will remind you about the Middle East Academy meeting that I have the honor to be managing its rhinology section since I think 17. And now, after being cancelled for a couple of times due to COVID, it's back in March, inshallah, 2020. So if you still don't have plans for March, please consider الميئة in Dubai, inshallah. So the case, it's one case scenario. She is an 18 years old girl presenting with severe headache, nasal obstruction. She also had proptosis and decreased visual acuity, papilledema, maxillary numbness, obviously due to something that we are going to see right now. So we have done for her CT and MRI, and I'm going to present for you what we have seen in her MRI. So now the MRI is playing, T1 with contrast, and I'm going from posterior to anterior. Let me show you what we have. So this is, I guess you are starting to see the lesion, and you know, in the temporal lobe, you have also lesions all the way anteriorly in the cavernous, and you're going to see also in the frontal, sinonasal, with extension into the pterygopalatine and the infratemporal fossa as well, pretty extensive. She was unlucky. So all the way anteriorly. And obviously the case, when presented with such a scenario, she was not just seen by me, she was also seen by our neurosurgeon. So we have kind of combined like discussion about what we are going to do for the case. The case has, I have got biopsy. So the biopsy came as...
ما كنتش قلت.
What?
ما كنتش قلت البيوبسي ايه؟ امال احنا جايين نعمل ايه؟
لا. It's straightforward. I mean, everybody's going to do the biopsy.
هي mostly straight.
So it's straightforward. It's a gynecological inflammation, as you see, as came from the biopsy report, which had also revision biopsy, like, you know, rereading of the slides. So it's gynecological inflammation with multinucleate giant cells and no evidence of malignancy, which was surprising. So the question is, in the next step, and this is the question for you, are we going to repeat the biopsy, or are we going to attempt to do an excisional biopsy in order to make sure that we are targeting every part of the mass? Or are we going to do immunohistochemistry, or maybe do some special stains or something? And I'm going to ask you to vote for that by going to, okay. So now you are requested to go, I'm going to show you, hopefully it's going to pick up. It's working? No, it should be there. Okay, so now please, everybody, take your phone, go to menti.com, okay, and enter this code, which is just everybody go to menti.com, please, and enter the code 43767795, please, including you if you can. And should we repeat the biopsy, do an excisional biopsy, immunohistochemistry, or request special stains? So I can see that one has already, just one, 6. Okay. I'm not gonna stop until maybe like 20, 25 people have answered already. So please go ahead. 14. Okay. How much? Like 20, 21. Please go more to 25. أيوة. لا يعني لو ما حدش عنده كونكشن اللي جنبه مثلا ممكن يساعده او حابب نكمل. ايوه. طب نشوف بقى كده الانسرز. So we have repeat the biopsy 1, excisional biopsy, like, you know, you go after every part, each part is 14, immunohistochemistry 9. Okay, now I don't like to show this in the beginning because, you know, like people get biased, right? But you see now, nobody is want to repeat the biopsy at all. Anyway, it's kind of, you know, the other 3 choices are kind of balanced. Oh, okay. Somebody wants to balance the other one, but anyway. Now, let's go to the presentation again. But maybe the highest one is for excisional biopsy, which is like kind of interesting. Like everybody is excited about the approaches, maybe, and wants to go after this mess and get really the appropriate diagnosis. Let's see. So here's the thing. If we see something like that in the histopathology, I always think about, you know, when you see multinucleate foreign body giant cells, it's something that's very characteristic with such a destructive mass in the sinonasal region, very characteristic to chronic invasive fungal rhinosinusitis, even if the histopathology does not show it. And I'm going to tell you why. Now, the invasive fungal hyphae could be there, but are not present in the histopathology whenever and wherever you repeat the biopsy or, you know, like revise the slide. And the reason for that is, you know, invasive fungal hyphae, yes, you can see them in HND slides, but this is like 50% or less of the cases. Same thing goes for KOH. It's not that sensitive. If you request, you know, your pathologist to either use PS or to use a silver stain, GMS, you know, then he might find the invasive fungal hyphae that are not there, are not seen by the HND. So you need to tell your pathologist that you have suspicion about such a disease. Then he is going to use a specific, you know, fungal stain, which is silver stain or PS. And why is that important? Because it might affect our approach or might affect our, like, you know, long-term management. So let's see. This is the next question. What's going to be your treatment for this case after you have kind of, you know, known the diagnosis? It's going to be complete endoscopic excision with, you know, like being a very experienced rhinology surgeon or skull-based surgeon along with your neurosurgeon endoscopically, plus the liposomal amphotericin B, or are you going to choose a combined endoscopic and external approach, which is, you know, as we have seen, different endoscopic external approaches that's going to help your endoscopic sinonasal approach along with an experienced neurosurgeon, like, you know, as we have seen from our great neurosurgeons presenting today, or we are going to be go just for endoscopic sinus surgery with antifungal therapy, and like, because you cannot do this intracranial portion properly. So this is again another question for you guys, and I'm gonna put the question there. Hopefully it's gonna pick up with the connection. Let's see. Yes, so please. So now the results are hidden, but you are welcome to answer, please. So it's going to be complete endoscopic excision, or combined endoscopic and external, or endoscopic sinus surgery plus antifungal therapy, since you cannot, or it's difficult for you to address the intracranial part. Please. So the first one is complete endoscopic. The second is combined endoscopic and external to make a complete resection possible, or endoscopic sinonasal just for the sinonasal part, and because you don't find it practical to attack the intracranial portion. So how many? Or let's see the results. Okay, which is reassuring. Now, I get myself excited with all the nice approaches that we have seen today, right? And I'm kind of, these approaches look amazing, and if I'm working with my expert neurosurgeon, we should do good for the patient. So people tend to get very excited, especially after such a meeting. You get like, I can do it. Somebody can do it. I will do it. Anyway, so I see that most of you have answered endoscopic sinonasal surgery plus antifungal therapy, although still 50% have answered the other, have chosen the other two. And let me tell you one thing. Like, so let's go back to the presentation. Honestly, such a lesion that we have seen already is a fatal one 2 decades ago, okay? And I have seen one patient dying from such, extensive lesion, being treated in order to remove every single part of this lesion surgically. But this was like, I would say, maybe 10 years ago, this was the approach. I'm not sure, but I have seen that happening again and again. And people, by the way, even some of the team that we were discussing this case wanted to go after this lesion to remove it completely. And things have changed. And the important thing is you just don't work. You work smart just as you work hard. Okay, so just don't spend everything working hard, forgetting about the principles of the work. This is the story about the chronic, granulomatous invasive fungal. That's a case presented in France in 2004, looking for a patient with chronic invasive getting into the orbit. And when this patient was treated with amphotericin B, the patient got nephrotoxicity. Itraconazole was then tried, was not effective after 2 years. And then voriconazole, Vifend, was tried for 1.5 years. Patient got cured. And when we see the antifungal sensitivity in this case, voriconazole was the sensitive one for this invasive aspergillosis. So this invasive aspergillosis also, this is the 2 years post-treatment outcome. And then 3 more cases from Japan, same disease, 2014. And they are presenting this small case series looking at this extensive example of chronic invasive fungal. You see with this intracranial extension. And by avoiding the extensive intracranial approach that's going to cause significant morbidity and mortality. and then taking care of the sinonasal part, and then putting the patient on voriconazole for 1.5 years. Again, remember the duration, almost 1.5 years. This is the patient pre-treatment, this is the patient post-treatment. And it's not magic, it's true. I'm gonna show you our own case. More 20 cases from India, and what they came up with is a pretty cool classification. If you have a completely, I would say, resectable lesion, then you can go for postoperative itraconazole or voriconazole. Itraconazole is more economic. While if you have a partially resectable lesion, okay, go and resect the parts that are practical to resect and go for postoperative voriconazole, and then all patients that they showed in their series with amphotericin B treatment alone showed recurrence or residual. And again, multi-center study, 6 patients presenting with chronic invasive fungal rhinosinusitis. Again, they have shown that the appropriate way to go is endoscopic sinonasal surgery for whatever you see safely in the sinonasal region to remove, and then choose the appropriate antifungal therapy depending on which organism is there, fungal sensitivity. So if we are talking about invasive aspergillosis, go for voriconazole, Vifend. You might have different stuff, different organisms. I have come across different organisms, by the way, not just the aspergillosis. So each one is going to have its sensitivity, and then depending on that, you continue with your treatment in the chronic. I'm talking about the chronic invasive fungal. Different story in mucormycosis, which the mucor is more sensitive to amphotericin B, of course. So the take-home message is to work smart, not just hard, and remember that there is a conservative approach for this kind of extensive lesion, going with antifungal therapy depending on the fungus. If it's aspergillus, it's mostly Vifend, in addition to the endoscopic sinus surgery. This is our own case. This is pre-treatment. This is 2 months on treatment, and this is 5 months on treatment. Now the patient is 4 years post-treatment. She's doing very well. She is symptom-free, and she's enjoying a happy life. And this is the residual part of the lesion that you see. That's it. Thank you.
Thank you, Dr. Islam. Thank you very much. Actually, as Islam said, these cases in the past, management was almost fatal in all cases, because such an extensive intracranial lesion cannot be accessed surgically with chronic invasive fungus. They are very tough, gritty, and adherent to all structures around. And any attempt to excise this lesion, whether endoscopically, endonasally, or external, is going to lead to death. Even, please, with cases like this, even if there is no intracranial extensions, usually these cases come in the posterior ethmoid and superior orbital fissure and the area of the optic nerve. Don't try to excise grossly. You will never achieve this. Just do, as Dr. Islam said, take a conclusive biopsy. المهم البيوبسي تقول لك إن دي chronic invasive fungus, and ask your histopathology to go for special stainings, methenamine silver stains. And at the same time, when you take the specimen, divide the specimen, one formalinized and the other on saline for culture, because this is very important to know the type of the fungus. This is crucial in the management. The problem again comes in the duration. Islam said 16 months, or in the literature coming from Japan. And believe me, 16 months is not a rule, is not a guarantee of the complete resolution. Islam showed very beautifully the residual pathology. You are not aiming at complete cure. If it comes, well and good. If it does not come and there is residual, you might need the antifungal, believe me, maybe for more than even 5 years, and some said maybe for life. This is not absolutely guaranteed or written yet. This is my experience.
So when, the experience that we had with these cases is we stopped the antifungal treatment maybe after 1.5 or 2 years, and then we follow up the patient, month by month.
Yes, yes.
If the patient develops any new symptoms, then we are going to do another MRI. If there is any change in the MRI with time, we are going to put the patient again on voriconazole.
Yes, yes.
تعليق صغير يا دكتور، تأكيدا لكلام الدكتور حسام. المشكلة ان العيانين بعد ما بنوقف الانتي فانجل الريكارنس للليجن بيكون مور اجريسيف. انا شفت حالة كانت كومبليتلي كيورد بالايميجينج. النكست ريكارنس كان ليجن انكيسنج كاروتيد.
Okay. Was it? So here's the thing. I have seen much more recurrences after itraconazole versus voriconazole. So like voriconazole is kind of like the one drug to go, or the one choice to go if you have a really unresectable disease, intracranial or intraorbital. The second thing is we follow the patient, even on regular visits. We don't wait like 6 months, seeing the patient after that, month by month. Once the patient develops new symptoms, or like even minimal symptoms, another MRI. If there is any change in the MRI picture, we go back over voriconazole.
I totally agree with you. أنا بشوف إن حتى لو هو did not develop any symptoms، رجوعا برضو الكلام دكتور مصطفى، إن أنت برضو preferably يعمل MRI at least بعد 3 شهور لو ما فيش developing new symptoms. لو في developing new symptoms طبعا يعمل immediate MRI. إنما even if there is no development of new symptoms, follow up MRI is يعني mandatory I think, and the long duration is the key for this. عشان كتير قوي بنلاقي خد فيفنت شهرين
صحيح
وقالوا له كده انت تمام. ف يعني it's a long time treatment و lifetime follow up.
صحيح الحقيقة.
Thank you.
انتوا عارفين قبل بس ما نقوم على قطمة الساندوتش اللي هنقوم له دلوقتي، اللي انا دايما بقولها، اللي هيعمل النقله دي هياخد جائزه نوبل، وانا كنت اتمنى ان انا الحقها، بس انا عندي البروف انه هيحصل نقله للكيور اوف كرونيك انفيزيف فانجس. هو ايه البروف؟ هو change in the immune scale بتاع البيشنت. ان انا هكشف السر، واذا حد يعني عارف بقى يوصل يشاركني معاه. انا قلتها اكتر من مره، كشفت امري لله، انه لو نقل العيان من الاميون كومبتنت ستيت للهايبر اكتيف ستيت. يعني ايه؟ العيان ده مش الرجيك، اقلبه الرجيك. انتوا هتقولوا عليا مجنون. انا عندي البروف ب2 patients chronic invasive fungus granuloma and it melts. انا بسميها كده انصهرت، دابت. يعني ايه دابت؟ الماس اختفت وحصل بوليبويد ميكوزا. بس مش بس بوليبويد، ده العيان بقى ايزونوفيليك بيشنت. ازاي حصل؟ انا شخصيا ما اعرفش، بس انا عندي البروف الاندوسكوبيك بيكتشر بتاعته موجوده في فيديوز وفي صور، ويمكن وريتها في اكتر من مؤتمر. and these patients cured of the chronic invasive disease، بس they are allergic دلوقتي، which is رحمه من ربنا. وانا مسمي حتى البرزنتيشن دي is allergy could be considered a mercy from God sometimes. could be considered. فنقلت العيان من الحته دي of the immune scale اللي هي stable immunity ل hyper sensitive، العيان ده هيخف.
Hopefully for the tumors as well that we have seen throughout the day, some immunological cure is going to be there. So we're going to avoid all these.
فنفكر بقى. قوموا إلى صلاتكم يرحمكم.
Thank you Professor Islam for this nice case.